Hi, everyone, and welcome to the show. We have a special kind of flipping the heads on this type of broadcast because it's not going to be Dr. John and I really hosting per se. We have the daughter of a 90-year-old peripheral artery disease patient. Peripheral artery disease is the disease we talk a lot about here on the show. It's one of John and I's specialties, right? And it's where you have those blocked arteries in mainly the legs that could restrict blood flow to the foot. If you end up with a wound on your foot, it may not heal because nutrients, especially oxygen, can't make it down to heal that wound. And that's what's really happening to Deb's mom. We're really excited. She's going to start out and she's going to share a little bit of the story. And then we have a vascular surgeon, Dr. Christopher Stout, who is here. We have an interventional radiologist, Dr. Dan Simon, who's going to be here in a moment. And of course, interventional cardiologist, Dr. John Phillips. So all of the main specialties that typically treat PAD are here, and they're going to allow Dee to ask them any questions she might have. So it's really going to be a demonstration of how do you advocate for yourself and how do you advocate for the ones you love. What do you think, John?
I'm number one. It's good to see your face. For those that are watching and those that are going to be listening, Kym got a haircut and her hair looks a little shorter. It's blonde. We all love it, and
The first time in years.
she's got vintage grandma's blouse.
Angora sweater.
Yep, on. Looking great. I am actually on location in Cambridge, Ohio. I'm working at our hospital there, helping cover because we're a little short-staffed. So yeah, I mean, normally you and I, we wax poetically and we have guests on that kind of, share their topics with us. But this will be interesting having Dee's perspective because she's obviously, it's her mom, but I get the sense that Dee's also part of the care. She's a caregiver to some degree. And so, and clearly involved in making or helping her mom make the right decision. So these are always tough cases when we've got patients who are of the extreme age. I mean, 90 is, she's not a spring chicken, and as they say, there's 90 rings, on the tree trunk there. So we have to be careful, but also it sounds like mom's pretty active, and so I'm looking forward to having the conversation. We have Dr. Stout, who's going to be joining us, or who is joining us. So we're going to have a lot of perspectives. Hopefully, we'll have some fun. It is the week before Christmas, so I'm in a good mood. So let's do this.
With all the bright lights that comes, like, how could you not be in a good mood? But it's also one of those, I think it's one of the busiest weeks when it comes to healthcare systems because everyone's rushing to get out for the holidays and patients are trying to get in fast before the holidays. And it always seems to be that as you approach Christmas or Hanukkah, like suddenly everyone emerges and they emerge in the emergency rooms. And you try to prevent that by just stacking your clinics all week long with as many patients as you can get in to make sure that there's no one suffering on the during the holidays when there
Yeah, I
are
mean,
fewer doctors
exactly.
available.
Because you've got family members that are coming in town that haven't seen, mom or dad or grandma and grandpa for a while, and then they look at them and say, "Geez, you don't look too good." And so, hey,
Yeah.
let's go to the hospital. I actually this morning did a little interview for our local, the Columbus TV station because they wanted to know about kind of like what events can happen from a cardiovascular standpoint during the holidays, and we did talk a little bit about travel and the development of DVT or PE for prolonged periods of immobility. We also kind of talked about we often sometimes see an uptick in cardiovascular events, heart attacks in the colder weather with snow and shoveling and all the
Yep.
vasodilatation, constriction, things like that. So there's a lot going on. Plus, you've got to shop for dad and family, and I've got to get my Christmas shopping in too. So it's busy,
Yeah.
busy
But
week.
we might even be having my dad. I've had to advocate for my dad urgently before the holidays. We are now probably going to end up doing a full angiogram on my dad's heart because he's just declining and fast when it
Hmm.
comes to his shortness of breath as he's walking, and everyone brushed it off before. And yes, he had blood clots. Now those are clear, but what if they are still in his heart? They found them in the lungs. Why wouldn't they potentially be in his heart as well? And maybe they didn't melt, or they don't melt with
No,
the Eliquis. They
sure.
didn't may not have absorbed um, with the medicine treatment. So now they're worried that maybe there's some in his stents in his right coronary. So we might have to get that. But that took a lot of advocating this week to push for that, before the holidays. I mean, the last thing I want is, heart attacks. What the number one day out of the year for that is Christmas, where the most heart attacks actually occur. So
Is that true? I didn't know that. That's interesting.
yeah, I had just read it that was it's the number one time of year for people to have a heart attack. So
And the guy that has the biggest risk is Santa, and he usually does pretty well. I mean, he's a jolly old guy. He's eating cookies and milk all the time. So we got to figure out what statin he's on.
I know, seriously. Well, I think it's about time we get things
All right.
started, and let's kick off with a moment of inspiration.
So I guess keeping with the holiday spirit, I was looking for some kind of interesting Christmas quotes. There's a lot out there about family and religion and things of that nature, but I found one on from Bob Hope, right? Bob Hope did the Christmas special, I think, for a really long time. And I like this one. And so he's quoted as saying, "My idea of Christmas, whether old fashioned or modern, is a very simple one, just loving others." And he says,
Oh,
"Come to think of it, why do we have to wait for Christmas to do that?" So I like that quote. Be kind of each other. Uh, there's, I would imagine, Kym, when you think about Christmas moments with your mom, they were pretty simple ones, right? Probably, around the whatever, but not complex, very simple, just being around family and loved ones. So it's important to remember that during this holiday season.
it is. That was the perfect quote. And speaking of loving others, we have Dee with us. Dee, just loving on your mom and so much pressure you have fighting and advocating for her life and her limb, right?
Yes, yes. Yeah, I know you know a little bit about the story, and I don't know how much you shared with the rest of it, but she has more complicated medical issues. She has congestive heart failure and coronary artery disease as well. And so she has all those additional medical issues, and so it was kind of like trying to find the best person to help her with her situation, given all her medical issues and whatnot. So, and one of the things I had trouble finding is, finding like somebody that actually specializes in the below the knee and her feet and the feet area, and trying to figure out like who's the best person to be able to, also given her medical issues, who would be the best to, handle her. So I was wondering, one of the things I was wondering is, given each of everybody's subspecialties or specialties, like, is there any particular like training that you'd receive in the like below the knee and the feet that, like, are there any specific fellowships or, after fellowship training that specializes in your respective fields?
I'll take that, and then I'll let the rest of the physicians comment. For me, no. I mean, as an interventional cardiologist, we play in small arteries in the heart. The calibers are pretty similar. They're a lot shorter in the heart, but similar diameter of those in the tibial vessels. And so those are the vessels that are below the knee and potentially, going into the foot. I did do some training out in Italy to learn from some of the physicians out there who have really kind of taken the whole below the knee, at least in my opinion, the below the knee intervention and into the foot intervention to the next level. So I was thankful enough to get learn some of their tricks and tips and get their insight. But really, whether you're a vascular surgeon, interventional radiologist, interventional cardiologist, in my opinion, you have to, if you're going to treat people with peripheral arterial disease, you have to be able to treat people that have critical limb ischemia, and the vast majority of those have blockages below the knee, and so you have to be able to kind of work in that space and help people get better blood flow into the foot.
And coming up right here on the Heart of Innovation, we're going to hear from an interventional radiologist, Dr. Dan Simon, and a vascular surgeon, Dr. Christopher Stout. They're going to weigh in just a moment. So we'll be back. Don't go away.
And welcome back, everybody. This is an interesting show. The coin has kind of been flipped. Instead of Kym and myself asking questions, we have our guests asking questions of us, as well as our guest physicians. So what I'm going to do right now is I kind of gave my little take, D, on my thoughts about working below the knee. Dr. Simon has joined us, as well as Dr. Stout. Dr. Simon, pleasure to have you on the show. Give us a little bit of your insight with respect to D's question, please.
Sure. So thank you for having me. And I apologize for joining late. So your question is a good one, and it could apply to anywhere in the country, which is, so who's the right individual, or what's the right training, or what's the right title for someone who can do sort of below the knee work? And the fact is, like, any of these people can do it, because the title is in fact not going to help you to the granular level of knowledge that you're looking, which is, so what is the experience level to work in these small tibial arteries? And certainly cardiologists are spectacular. They're all great, platforms, whether it's vascular surgery, interventional radiology, interventional cardiology. These are all potentially very well trained, skilled individuals. And so I don't think any training is necessarily going to eclipse any other by title. It's really, where does the operator choose to emphasize, and what's their skill level, and how comfortable they are. If I were to say, how do you ferret out in a particular geography who's the right individual to work? I had this question posed to me in New York, kind of where I live, which was, my dad needs a TAVR procedure. Where should it be done? Cornell, Columbia, NYU, Sinai, Montefiore, which hospital? And so if you said, okay, and to answer that question, I said, who I'm going to call? I'm going to call the companies that manufacture the TAVR devices and say, okay, Boston Scientific, okay, Edwards, who are the reps? And then say, tell me about the teams in these places, and who's good, and where would you go, that sort of thing. And so whatever geography you live in, you could say, okay, the operators who are going to be doing tibial work, which is what we're talking about here, you could say, let me talk to the laser people, let me talk to the CSI people, let me talk to the balloon reps, let me talk to the, stenting in that area is a little more advanced, and potentially yes or no, but certainly everyone's going to be doing an angioplasty. And so if you wanted to kind of understand who is super comfortable in that space, who is doing it on a regular basis, and I think from seeing some of the prequel to this show, I think this is Sacramento market. I don't know, even though I trained in California twice in my career, in LA and San Francisco. But I would say one way to get knowledge in the operators who are there and who are very comfortable would be to speak to the reps, get a hold of the drug company. Get a hold of the device people in that area and just ask questions. It's not that that's the final answer, but you're essentially doing some detective work. The other thing I would give a shout out for in this area, again, I don't have the full history and all that stuff on this patient. These tibial artery disease patients, they're often very sick. I think the CHF was in there. Wouldn't shock me if there's diabetes, COPD, renal insufficiency.
There's chronic venous, right, chronic kidney.
Yeah, there's quite a long list here. And so the other thing that we do a lot of, and I'm not saying it's a complete, it's a deal breaker. We do an enormous amount of carbon dioxide imaging. Okay, if you're going to play around in tibial vessels, if you're going to make this your business, your space, your area of expertise, you better be highly comfortable as an operator imaging with 1 ml, 2 ml, 5 mLs of contrast. That's the whole case. That's the complete tolerance. You get very few shots on goal. And if your operator cannot do this case with less than 10 or 20 mLs of contrast, then perhaps that needs to be at least a consideration in terms of selection, because there's always choices to be made. There's always sacrifices. There's always a downside. We do not want to put anyone in a position where dialysis is the outcome for an attempt to save a limb. There are implications on both sides of that, but certainly today in 2023, soon to be 2024, there are ways to accentuate imaging, in particular carbon dioxide imaging. And so if they are not doing carbon dioxide imaging, if that's not something that they've done in the thousands, as far as I'm concerned, thousands, then I would look elsewhere. It's just me, East Coast, Jersey, but I would say that is those kidneys should not be put into jeopardy to answer particular questions anyway.
Mm-hmm. So you're saying like 20 mLs would be the maximum to use for contrast dye?
Unfortunately, it's not there's a threshold upon which you cross, where it's unacceptable. But we've done, a big part of our practice, my practice, is we're seeing patients with creatinines of 1.92, 2.5, 3, 3.5, and they're not on dialysis, nor do they want to be on dialysis, nor do we want to be the culprit that puts them onto dialysis inadvertently. And so we've, and again, we do a lot of, a fixation on this in terms of imaging. Here's my analogy. Once upon a time, if you wanted to take pictures, and good pictures, you had to have like that camera and then buy the film with the f-stop and the shutter speed, and you had to know all that stuff, right? Like I'm shooting in dark and all that business that makes up photography. Nobody does that anymore. We have an iPhone, we take it out. Now everyone's a photographer, and a pretty good photographer at that. But when it comes to medical imaging, when it comes to doing these angiograms, this equipment we use, it's fantastic. It's really amazing, the technology here. But every now and then, we, the operator, vascular surgeon, cardiologist, interventional radiologist, maybe an interventional neuroradiologist, maybe an interventional nephrologist. The list keeps growing as to who's doing what and using what equipment. But at some point, you're taking pictures, and the equipment is doing most of the heavy lifting. And all that's true up until such time as someone says, well, the creatinine is close to 3, and we've got to really limit the dose of contrast. And so now you enter the world of carbon dioxide imaging. We used to use gadolinium to get around this problem. That's an MR contrast agent, but even that's now verboten because there's an issue with the kidney's excretion of the gadolinium, or the gadolinium-based contrast. But that metal is now a problem we've come to recognize. So the gadolinium or the MRI contrast agents, which we were borrowing to use in angiography, we don't do that anymore. You're in the world of carbon dioxide imaging. That's going to do most of the work, but that's kind of tricky and annoying, and you're back in the 1960s with cameras. You got to figure out, what's my angle here? How am I taking this picture? Can I adjust the brightness and contrast? The only way to learn this is to do an enormous amount of it. And so the people who've done it over and over and over again are the people who are like, yeah, we can do it. And we can get away with 5, 10 mLs of contrast to kind of do this case. The other thing is setting goals. When a patient with normal kidney function, you might say, listen, I'm going to fix everything on this screen. In a patient that has a creatinine of 1.9 or 2 or 3, you might say, there's a multitude of problems in these tibial vessels. We're going to pick one and fix it. And that's our goal. That's it. We're fixing this one tibial, because we're going to come back 2 days later or a week later after these 3 mLs of Visipake, which is a contrast agent, have passed through this patient, and we're going to repeat their creatinine and make sure we didn't do any damage. We're going to bring them back. We're going to fix that other tibial. What we're not going to do is be overly ambitious and greedy and try to fix everything on this visit and expose this patient to 10, 15, 20, 30, 40 mLs of contrast. We're going to come back and fight another day. That's
Dave,
what we're going to do.
Great conversation there. We've got to go to break, but coming back on the Heart of Innovation, we will continue to field questions from Dee regarding her mom who has critical limb ischemia. Welcome back, everybody. Thanks for joining us. Having a great conversation here today with Dee regarding her mom who has critical limb ischemia. So before we went to break, Dr. Simon was kind of speaking about some of the perils of performing angiography with contrast and some of the alternative methods that we have to visualize the arteries. Dee, you had a question regarding that still, or was there something else?
Actually, I didn't know he was going to. I'm sorry he has to go. It was really enlightening, and thank you for sharing your insight, Dr. Simon. One of the things I was wondering, my mom's particular case, she's also concerned about doing it under general, and I was wondering like how long the procedure lasts. In her particular case, like how long would it last? If there would be a chance of her going under general, and if she would have to do that, is there a way that she could specify before the procedure, like if it required that you could just not do the operation and not do the procedure? Is that something that's doable? And then also if my mom has really restless leg, like they jump. I don't know if it's a technical definition of restless leg, but she has like, maybe some people have said myoclonus possibly, but I'm not sure if it's truly what it is, but she has spasms, and at night mostly. She just had a heart cath last July and she just did MAC, she just did Twilight for that, and she was fine. When they did the pacemaker, she also had a heart cath last April, and she was fine. She just had Versed and propofol, at the time, so she was fine for that. But I know they're in the legs, and obviously that's a little bit more whatever. And is it going to be a longer procedure? Like how long would the procedure be? Is that possible to do that? And then the other thing I wanted to ask is from the office-based lab with my mom's medical conditions, would it be better for her to stay at a place with a hospital that she would stay overnight to be monitored, because she does have CHF, she does have 100% blocked of her LAD, and another one, you know what I mean? And
there's a lot to unpack there. I'll put my 2 cents in and then let Dan comment on it. So the use of general anesthesia, I would say 99 of 100 cases I use just Twilight. For most folks, that's enough. There's not a lot of pain involved. Really, the rate limiting step, as you mentioned with the second part of your question, is the patient's ability to be still. With the heart catheterization, the legs can move, doesn't matter because the chest and torso is not moving. But if the patient can't keep their legs still, if they're fidgeting, well, we're taking images, the images get thrown off, they're blurry, we can't see. And so if I'm seeing a patient in the office and they're telling me I have a hard time keeping my legs still, and I'm moving around, it's not, and again, they're not trying to do that, they can't control it, then for me, we need some type of sedation to keep them kind of from moving. Obviously, at 90 years old with other comorbidities, you have to be careful about general anesthesia, but possibly having an anesthesiologist there that can kind of help with a more aggressive anesthetic would be my recommendation. I don't have an office-based lab, but clearly, mom's pretty old and has some comorbidities, and so potentially, maybe being in a place if something, where she would be needed to be monitored overnight might be a benefit.
Mm-hmm.
Yeah, I think John is very correct in saying, man, there's a lot to unpack in your question, and it's a great question. No, it's a great question. So I work in several office-based labs, and so in some we have anesthesia and some we don't. And this question of some of these things are largely in a crazy way. Just step back. Medicine is the judicious practice of common sense. That's really what it is. Okay, evidence-based, judicious common sense. And so someone's going to move their legs, and that is actually going to degrade our imaging, and it's a real problem. And we face it all the time. And so, as crazy as may seem, and we balance this, why do we even care about anesthesia? What's the big deal? Why not just put everyone under anesthesia? It's because itself, the action of anesthesia carries particular risks. Again, there's no free lunch. And so we try not to use anesthesia, and we use Twilight, and Twilight kind of has different definitions. And I'll often introduce the team who's handling anesthesia as this is our bartender for the day here, and she knows how to mix these drinks, and you'll be happy, is often what I will say. But sometimes the best is nothing. We're going to give the patient nothing. There's 2 parts to this. The first part is the taking of the pictures, just building this map of like we understand there's a problem, but in fact we don't really know the granular nature of what is blocked, open, not blocked, treatable, not treatable. We've really got to take pictures, and the better the picture, the more helpful, and the less movement, all the better. We actually have these Velcro straps, which we use to really immobilize the legs. And so we would much rather put several of those on and use nothing and just work through the restless leg syndrome or the movement. And so very small doses of fentanyl, Versed, we used to actually use a drug called droperidol. It's an anti-nausea drug, but in fact, it is in the Haldol family, and it kind of actually just mellowed people out. Anyway, what the goal is, little movement, take pictures, and then work off those. It's hard to say just what you're telling me where your mom should have it done, because in fact, this is again such a regional focused personal preference. Like one doctor saying, I can't do this case, is another person saying, we do 50 of these. This is no big deal at all. Okay. And so it really is, trying to ferret out from an operator, what your comfort level is. I think John's point is, you sit with a patient beforehand and you kind of get some sense of just how possible or not possible. But even that, Norman Schwarzkopf said, no battle plan has ever survived an encounter with the enemy. And so you can, of course, come up with, from your meeting and your physical exam and everything, you got a sense of, okay, how this is going to go, except on the day you do the test, everything could go out the window. And in fact, we've seen patients where the first angio was horrible, absolutely horrible. And the next time they come, because we're not trying to fix everything at one time, it's fantastic. They're great. It's just an absolute pleasure. And the reverse is also true. Where they're spectacular on the first visit, and a week or 2 weeks later, it's a completely different person who's on that table, especially in a 90-year-old with CHF who's going to be in a slightly unfamiliar environment. All bets are off necessarily. I used to be super anesthesia until I found myself working at a hospital where I was the guy who ran the stroke team. And often we would go up, I would call anesthesia and say, we have an active stroke. And they'll say, we'll be there in an hour. And I would often want to say, this train is leaving the station in the next 5 minutes. And you're either on it or not. I could care less. You want to show up? Fine. But we are not delaying, treating a stroke because you can't pull someone from a knee replacement or whatever. And so we've learned to work around anesthesia, but that's us. That's us and in particular circumstances. And so it's very hard to give like a broad answer to your question, which is really just, again, it's sort of a common sense question. Like, my mom's 90. Is she spending the night? Typically, we don't admit patients. We don't have anesthesia. And we're able to do this all outpatient. Typically, right. It doesn't mean your mom's going to fall in that box.
Thank you so much, Dan, for being here as well. Dr. Dan Simon out of New Jersey, Interventional Radiologist. We appreciate you. We're going to come back with Heart of Innovation and Vascular Surgeon, Dr. Christopher Stout. So stay with us. Welcome back to the Heart of Innovation. We are with Dee. She is advocating for a 90-year-old mom. We are trying to get multiple perspectives from the practices that mainly treat peripheral artery disease, those blocked arteries, and mainly the legs. Her mom has advanced stage, which is critical limb ischemia, is what it's known as. And so she's debating, well, do I have a procedure to open the arteries? What doctor do I go with? Is it practice specific? Should I be having her do the procedure in the hospital or an office-based lab? Like, oh my gosh, so much pressure. Before the break, we were talking to an interventional radiologist, also Dr. John Phillips, an interventional cardiologist, weighed in. But we also have Dr. Christopher Stout, who is a vascular surgeon. So I'm going to let Dr. Stout jump in here and explain the practice of vascular surgery and the value in going to this practice as well. Dr. Stout.
Yeah, very good, very good. Thanks for having me on here. A vascular surgeon, we're trained in how to do the angiograms and revascularize the lower extremities. In addition to providing, we're trained in how to do the bypasses if the angiogram fails. And I'm a firm believer that if it looks like it's able to be done with an angiogram, it's much less invasive, much less risky than a surgical bypass, which does require general anesthesia, does take multiple hours, does require, a week in the hospital, and it takes months to recuperate from it. So getting back to some of your questions on the risks and, should this be done, we generally will evaluate a patient, whether it's Dr. Simon or Dr. Phillips or I, will evaluate the patient before we do any procedures. And that's part of the defining their anesthetic risk and also their airway. And we look at, what is their heart failure? Okay, is their heart failure, are their legs swollen today? Are they short of breath? No, they're okay. We know that there's some coronary or some heart disease in there, and no matter which way you look at it, an angiogram still carries a small risk of developing a heart attack just because of the stress of the procedure. It's very, very small compared to surgery, definitely, but there is that risk. So I operate in OBLs in addition to hospital spaces, so I have a pretty good perspective on that. And I much prefer to do cases in my OBL first, even on the 90-year-old with CHF and LAD lesion, as long as they look good on my pre-anesthetic evaluation that day. And like Dr. Simon said, I've evolved to not using much anesthesia. And in the patients that have a lot of leg movement and things like that, I find that the less anesthesia you give, they can focus a little bit more. The patient can focus on, I'm going to try and keep my legs still. But when the patient is heavily sedated, then there's a little less inhibition, and they don't know, and their legs seem to move quite a bit more. One of the good medications I like is ketamine, which you got to be careful with ketamine in patients with high blood pressure, etc. So again, it's one of the things, it's like the bartender is going to mix a drink, and it may be, this medication or that medication or this combo. So all very good information for you here to be able to get you some information. Now, CO2 is a definite must, especially in anybody with chronic renal problems, because you don't want to push somebody onto dialysis or even push them up into where they're chronically renal insufficient. So then you bar them from other tests in the future. So I think CO2 is great. And, one of the questions asked your doctor, do you use CO2? Yes. Okay. When you do use contrast to see my lower extremity arteries below the knee or in the foot, if I'm trying to do, revasc the foot, ask them, can you use a 3 cc syringe? Because when you use a smaller syringe like that, you're less apt to push it all in there as a, operating physician, especially if the legs are moving and you're starting to get a little bit frustrated. Using those smaller syringes will limit your contrast usage significantly. And you can do a case with just a few milliliters of the contrast and get a great result. So I agree with what everybody is saying so far. And I think that, find a doctor that will give you minimal anesthesia, and it's your preference and their evaluation of whether it's an OBL or a hospital. But think about what exactly is going on with the patient, and that will help you decide that. And the interventionalists, you've got to really be careful, because you're going to find really good vascular surgeons that can fix below the knee stuff. You're going to find guys that don't even take pictures or do angiograms below the knee, and vice versa with interventional cardiologists and interventional radiologists. There's just a big variability, and asking the reps, or if you have a contact that can ask a rep, such as Kym, that is a great resource for you. So and Kym knows everybody, so you can't go wrong there.
You're giving away one of my secrets.
Yeah, just one of what you said about the big variability within your subspecialty. What is the particular training, or is there an extra courses or certificates that you do after your fellowship training that specializes in below the knee and in the feet? To get the training, is it part of your fellowship, or is it added on the job afterwards? And what, who's doing, within vascular surgery, where are the fellowships that are more focused on, what centers are focused more on below the knee stuff?
Yeah, that's a very valid question. And you're going to find different fellowship training programs that they focus more on fixing aortic stuff and large aneurysms. And then you're going to find other fellowships where they focus more on doing more peripheral vascular disease with, angiograms. And then you're going to find those programs that they're trained on how to do bypasses and they don't do very many angiograms. In order to graduate a vascular surgery fellowship, you have to perform a set number of angiograms, a set number of open bypasses. So you get trained on them, but you're only going to be as good as the faculty that train you. So if the faculty that train you are, they can put a stent in an artery higher up in the pelvis, or if they can, do something in the upper thigh arteries, but they're not good down below, you're not going to be good down below when you get done with your training. And, I don't want to go through all the different programs out there because there's, multiple programs, and it's difficult to kind of pick that apart. And your best option is, talking to guys like me, or talking to reps, et cetera about that. Now, in terms of below the knee is, it's a very complex disease process, and there's smaller arteries, and you've got to find somebody that has a passion for peripheral artery disease. If your doctor comes in and talks to you, your vascular surgeon or whomever, and basically spends 5 minutes with you and says, yep, you got blockages down there, we're going to try and fix those, but we can definitely fix the ones up here. That's probably not the right guy. The right guy is going to say, well, these are tough, we're going to try and open up this artery, but we got to make sure there's flow into the foot from that artery. You can kind of get a good sense from your discussion with them. If they talk a little bit more in depth about the below knee arteries, then they're probably going to be a pretty decent interventionalist.
Mm-hmm. But is there any after your fellowship training? I mean, I don't want to just necessarily what centers are doing the best in lower leg or whatever. But after that, are there any other courses or on the any kind of on the job stuff that you can participate in, or you do participate in?
Yeah,
what
definitely.
Would that be? Like, what are those? Are they like any kind of certificate stuff, or I mean, I don't know.
No, there's no extra certificate to get CLI certified. I mean, there's different. You can always get a certificate that says anything you want to make you look good.
Right. Yeah.
But there's no dedicated great program out there that says, okay, you're going to spend an extra 6 months and all you're going to do is below the knee angiograms and fix all this stuff. You're going to pick all that up in your fellowship training. You got to choose your programs accordingly. And now there's courses, different things that they're put on by the societies, and different people with different meetings that put on courses where you can practice getting pedal access and using different devices to treat different diseases, and whether it be a cadaver or a pig. There's definitely that option out there for the guys that need some help. But I've found a couple I've taught some of them courses. I find them to be pretty rudimentary to kind of get guys springboard into it. But for the most part, you learn a lot of this with experience doing, hundreds and thousands of these cases, like Dr. Simon said. You've got to have that experience, because it does matter, because you learn that, well, I don't see any artery right there, but I see something clear down there. So blood's getting there somehow. And I'll bet you that artery would fill with contrast. It's just got the blood flowing in the reverse direction because it needs to get blood back up to the calf muscle. So you go after that artery, and all of a sudden you've got a nice artery that goes from the knee to the ankle because you gave it a shot, knowing from your experience that there's a lumen, that there's something there to fix. So that's unfortunately, in the US, there's not a dedicated CLI program.
So it's just kind of basically
right here on the Heart of Innovation. We'll have just a few moments to wrap up and give some final pieces of advice to Dee as she is advocating for her mom for her life and limb. So stay with us.
Welcome back, everybody. So we're wrapping up our show. Been very insightful. We've had the privilege of hearing from Dee, who's taking care of her mom who has critical limb ischemia, and Dr. Simon and Dr. Stout have kind of weighed in. With the 4 minutes left, my 2 minutes of sense are, when you're looking for a proceduralist to help your mom, there's a couple of questions that you want to ask, in my opinion. And one of them is, do you do this procedure? Like, how many do you do? I have patients ask me how many patients I treat with critical limb ischemia, and I know the numbers. They ask me, what are the risks? And I sit down and kind of talk to them about the risks. Well, there could be a bleeding complication. There could be a multitude of things, and your mom's 90, so the risks do go up a little bit. But in general, the way I approach a patient who has critical limb ischemia, where they are staring down potentially a major amputation, and I might be able to help them, the likelihood of me killing your mom is very, very low. The likelihood of me having your mom go into renal failure from contrast is very, very low. The complication rate, I would say maybe 2 to 3% of a major complication. But the beauty of the procedure that we do from an endovascular approach is we can try, and even if we're not successful up that artery, we're probably not going to make her worse. And so I am very aggressive in patients, regardless of their age, if they're an appropriate candidate for an intervention. But you've got to go into that initial visit with your physician, whoever it's going to be, a surgeon, interventionalist, ask some pointing questions. What's your volume? What are your outcomes? I've never had a patient ask me, can I talk to another patient? But I mean, there's a lot of folks out there that dabble in the space, and then there are, I think, a little bit less that are actually truly CLI kind of interventionalists, and you want to find somebody that's a true CLI interventionalist.
Right. Well, what if it depends, like if they would say, what the outcomes depend, because, people have present with varying, degrees of comorbidities, and it's going to be dependent on that, or what is the, it's going to be variable.
In my opinion, it's pretty standard. I mean, so you look for, we have to put a tube in at some point to get access into our artery. So there could be a complication from there. But again, I quote patients a less than 3% risk of a major complication. Most of my patients go home the same day. So you can do it in an office, as we had talked about, or you can do it in the hospital. But there always is some risk involved. But again, you'll get a sense as to what that physician's comfort level is with the procedure, the more you kind of discuss the process of the procedure itself. And if they're not doing a lot of these, then you want to find a doctor that does a lot of them.
Right. But a lot of times, I mean, it's kind of like putting on the spot too, like, to ask somebody that, and then also, if they just say they do a lot of them, I mean, if you try to quantify it, I mean, it's going to be like, oh, well, a lot, it's going to flip off the answer,
I think that you're going to find.
What's that?
Dropped out. If the physician gets upset that you're asking the question, walk out. Number one. If the physician kind of hems and haws about it, walk out. If the physician looks and goes, "Oh, don't worry, we've done plenty of these," you can get a good idea of being and trusting that physician. And there's going to be a risk with angiograms. I think in this case, I would be very hesitant to do a surgical bypass. Your risk of surgical bypass is going to carry a 7 to 10% chance of infection in wounds just that you created surgically. And those are going to take 3 to 5 months to heal up on their own. So with her wound, I would be very careful on doing a bypass. Like that would be absolute last resort. But do a diagnostic angiogram and then trying to fix, relatively decent stenosis, especially if your digit pressures are low, or if you got some other perfusion analysis saying that your perfusion pressure, your DBI is less than 0.6, then I would definitely go for the angiogram.
Right, definitely. Yeah, wasn't considering bypass at all. But so if you do, so when you're doing the risk, so basically what the risk would be for doing the procedure itself, you know what I mean? Like for bleeding or for stroke. I mean, it's 3 to 4%. I mean, for each one of those categories, like hematomas, like perfusion, like, you know what I mean? Like,
yeah, for just the angiogram itself, I think that your risks are going to be 3% or less, especially if it's diagnostic and use CO2. I think that you're going to get out most of the time without any issues. If you need to go in there and angioplasty or even use an atherectomy device, your risk can go up a little bit, but I think you're still going to be at 3 or less. And those risks are mostly going to be bleeding from the groin, maybe a pseudoaneurysm. Most of those are remedied without surgery or any other major remedy. So it may take more time. You may be in a hospital for a day if you need to, but I don't see any big issue with you can't predict it. But I think that the risks are probably relatively small, provided versus the benefit of the toe wound, especially if it gets worse. Then your risk benefit ratio changes.
Thank you so much. We really appreciate all of your perspectives, Dr. Stout. Thank you so much, Dee, for your vulnerability and your courage and for your fight, to advocating for your mom's life and her limbs.